order. So we have Dr. Sheri Lippman. Sheri is associate professor at CAPS and epidemiologist conducting clinic and community-based research in South Africa, Brazil, and elsewhere. I guess all the places where COVID variants are popping up, huh? And to improve uptake of HIV testing and engagement in care through identifying the key social and structural factors that shape engagement with the health system and addressing these barriers through intervention research. She's the PI of a cluster randomized trial to assess the effects of community mobilization on HIV treatment outcomes in a high HIV prevalence area of South Africa. Following completion of the iCare trial, she has adapted personal support and navigation interventions in clinic environments for multiple target populations, including MSM in South Africa and transgender women in Brazil. She also conducts research to investigate the use of HIV self-testing to broaden access to HIV testing and early diagnosis. She is director of the CAPS, currently called Intervention and Implementation Science Corps, and it's got a new name, which I'm not going to try to do right now, for the next iteration of CAPS. Joining Dr. Lippman is Dr. Jay Sevelius, and Jay is an associate professor at CAPS and a licensed clinical psychologist whose research focuses on the investigation of risk and protective factors in transgender and gender diverse communities and relationships between intersectional stigma, gender affirmation, and health-related behaviors and outcomes. More recently, the research has focused on developing and testing peer-led interventions to promote sexual health and resilience among transgender people by addressing intersectional stigma among transgender women of color and those affected by HIV. Jay is also co-director of CAPS and the co-director of the CAPS Developmental Corps, and PI and founder of the Center of Excellence for Transgender Health. So today, like I mentioned, we're going to be having 3 presentations. The first one, as far as I know, is our 2 speakers will be presenting together on a project that they're multi-PI of. This is an R01 entitled Reducing Intersectional Stigma Among Transgender Women in Brazil to Promote Uptake in HIV Testing and PrEP. Then Dr. Lippman will talk about her K24, and I'm hoping that one of you will explain to everyone what a K24 is when the time comes, on training and implementation science research to improve PrEP services for people at risk for HIV. And then Jay will talk about their K24, which is also focused on mentoring clinical investigators in patient-oriented research in substance use and HIV. So there's a lot to get to. I will turn it over to our speakers, and I look forward to learning about these new projects.
Thanks, Mallory. It's really a pleasure to share the stage with Jay and to get to an opportunity to talk about both the R01 that we wrote together and also about the new K24s that we have, because these are things that Jay and I have been working on for quite some time, and it's just a pleasure to get to share them with everybody. So thanks for being here. I'll just, Mallory read my bio for you all, so I won't go into too much detail, but yes, I'm an associate professor with a Ph.D. in epidemiology. And most of my work focuses on the social environmental factors that are increasing our vulnerability to HIV infection and poor care outcomes. So my research really looks at designing and evaluating intervention programs to address those factors. And most of my NIH and CDC funded research is really focused on community mobilization, self-testing, and then peer support programming. And the first project we'll be talking about today is a peer support program, Manas por Manas. Jay, do you want to do a quick intro, or should I just jump into it?
Oh, let's just have you jump into it.
Okay. So Manas por Manas is a project to reduce intersectional stigma among transgender women in Brazil. The partners on this project include myself and Jay as MPIs. Also, our site PI is Maria Amelia Verdas, who's at the Santa Casa School for Medical Sciences in Sao Paulo. Our group is also joined by NUTHIS, which is an LGBTQI plus human rights study group located in Sao Paulo, Brazil, and founded by Amelia about 4 years ago. We'll be working with 2 clinical sites in Brazil, the Reference Center for HIV/AIDS, the CRT, which is a state health department site that has a large transgender program nested within the clinical site, and also with the Sai Campos Elíseos, which is a care and treatment center located in central Sao Paulo and run by the municipality.
And I'd just like to add that we also have Sofia Zamudio-Haas, who was awarded a diversity supplement to work with us on this project and created a sub-study that she will be leading.
Yeah, and if we have time, we can talk about that for sure. So, this project really draws on components that Jay and I have been working on for quite some time. We've previously established acceptability and feasibility for a lot of the work that's sort of been pulled together into this Manas por Manas project. So this work includes building group level interventions and individual level interventions with trans women, as well as a history of establishing feasibility and efficacy for the various prevention strategies that we're using, which include HIV self-testing and PrEP use. So I just wanted to throw this slide in to say that this is built on about 10 years of previous research, really developing a portfolio that brings in a bunch of different strategies and a bunch of different peer support type programming, working in groups with dyads and with individuals, so that we could bring it all together in the Manas por Manas project. Excuse me. So the specific aims of Manas por Manas is to address, well, the overall objective is to address and reduce the negative health impacts of intersectional stigma on transgender women that they experience to improve HIV prevention strategies. So our first aim is an HIV testing focused aim, where we determine whether HIV testing uptake is higher among trans women in the Manas por Manas intervention compared to the waitlist control arm in our intervention study. Aim 2 focuses on prevention. So we'll be determining whether PrEP initiation and persistence is higher among trans women and Manas por Manas compared to our waitlist control arm. And our third aim is really about mechanisms. So we'll be exploring changes in intersectional stigma, including reductions in internalized stigma and increased resilience to anticipated stigma and enacted stigma. And we'll be assessing how those changes impact the uptake of prevention, but also interaction with our intervention program. So we're combining 2 evidence-informed interventions, group work and individual level navigation, which is really a dyadic intervention as part of this study.
So just a little bit of background about HIV in Brazil among trans women. Clearly, transgender women in Brazil experience extremely disproportionate rates of HIV, about 25 to 30% HIV prevalence in southern Brazil, and infection rates are more than 55 times that of the general population. Interestingly, PrEP is technically available nationally, but only 335 trans women had initiated it by late 2019. We see a lot of structural barriers to uptake of PrEP, including lack of providers who are prescribing PrEP. And generally, low uptake can't really be attributed to a lack of interest among trans women or a lack of eligibility among trans women. And we also see low rates of testing, which is not commensurate with the risk of HIV infection. So the framework for this project and this intervention is really based on intersectionality, which is a confluence of stigmas or forces of oppression that are related to social identity. And in this particular project, we're focused on gender, race, social identities or behaviors like sex work and substance use, as well as HIV stigma. And so, as Sheri mentioned, we have a strong evidence base for peer-led programming. And the intervention is really led by trans women themselves. And so we're targeting the individual as well as the dyad of peer navigators, participants, and group. And our programming is really empowerment-based and gender affirming. So the conceptual background is based on years of work in the model of gender affirmation. And just to quickly introduce you to the concept of gender affirmation, we really think of gender affirmation as having three primary domains, where among trans people, medical gender affirmation is access to things like hormones or surgeries for those who want them. Not all trans people pursue hormones or surgeries, but medical gender affirmation can also just look like trans affirming care. So healthcare that is very affirming of one's gender, inclusive, compassionate, and knowledgeable. Psychological gender affirmation is that internal sense of affirmation. It's self-affirmation, pride in one's identity, feeling good about oneself as a trans or gender diverse person. And social gender affirmation is what we think of when people use the correct pronouns, the correct name to address a person, use an inclusive approach socially, and legal documents can also be considered social gender affirmation because they affirm a person's gender in a social way. This is the, sorry, I didn't go over intersectionality, which I briefly mentioned was a theoretical approach that highlights how multiple types of oppression intersect to create and reinforce social inequalities and health disparities. So just to reinforce the notion that this is really about social forces and oppression, it's not about stigmatized identities or that the stigma lives within multiple identities as is often described when people talk about intersectionality, but it really requires that we take a step back and think about the social forces like racism, transphobia, and other types of oppression that cause social inequities. This is the conceptual model for our intersectional stigma reduction intervention, Manas por Manas. We're looking at the intersecting stigmas that are associated with identity, specifically trans identity in this study, social position or social behaviors like sex work or low socioeconomic status or substance use. And we're also looking at HIV and PrEP stigma as part of that intersectional stigma. The types of stigma we're looking at are internalized, anticipated, and enacted. And health behaviors such as reduced self-care behaviors, avoidance of healthcare settings, low levels of stigma resilience, which can ultimately result in negative health outcomes. But our intervention is really intervening on these levels of stigma at the group level and individual level to increase self-care, reduce avoidance of healthcare settings, increase stigma resilience, and thereby increasing the uptake of HIV prevention among those in the Manas por Manas intervention.
Okay, so we're just tag teaming here, keep everyone on their toes. So the Manas intervention is set up in two parts. So the first is a peer-led group work, and this takes place over 5 to 6 sessions. Really, it's 5 sessions and then a reunion session that meets again a few months later. And the sessions are based on successful adaptation of Jay's Shiro's intervention. And it also incorporates some of the successful group work we did during our Trans Amigas peer navigation program in Brazil, which was an R34 we had in 2018 to 19. So we select peer leaders, we select them in pairs, and we aim to have both an HIV positive and HIV negative peer navigator leading each of the groups so that we can really address the HIV related stigma as well as the PrEP related stigma head on. The peer navigators lead groups of about 8 to 10 participants through group work designed to bolster trans pride and gender affirmation and to address HIV prevention, as well as safe transition practices to address experienced stigma in the community, in the healthcare context, and within their relationship. And it offers tools for resilience to experiences of stigma. Once the group sessions are completed, then each participant is assigned to one of their group leaders for 6 months of one-to-one navigation support. And that's designed to really help participants with their experiences of stigma and other barriers to prevention and well-being, and to support them as they continue working towards sort of prevention goals, well-being goals, and also their gender affirmation goals. And they lay these out for themselves. So the navigator helps people really come up with a plan of action of things that they want to achieve and help them go through different activities to get to their end goals. So it's really a combination of structured and unstructured activities and check-ins that the navigators do to address people's individual barriers to care. So these are the titles of the group sessions that we have manualized for this program. So for example, the session on gender pride explores trans identities and explores gender pride through identifying positive role models to combat internalized stigma. We introduce HIV prevention options in relation to concepts of self-care, self-worth, and sexual health in that session. We have, a session like the session on taking back the power, for example, discusses how trans-related stigma impacts one's sense of personal power and explores ways to reclaim one's power to confront stigma. So during that session, the participants explore assertiveness skills and practice communication skills for the healthcare context. They actually do role play. What happens when you get to a clinic and they call you by the name that you don't call yourself. So we use that session to really challenge these structural and interpersonal experiences of enacted stigma. So each group session includes a moment to discuss and reflect on one of the Sheroes or trans women heroes. Again, this comes from Jay's program that was first piloted in the US. This is somebody who inspires others to really move forward with their work. We've also integrated guided visualizations and mindfulness work into the gender affirmation exercises, which is so important right now as all of us are just experiencing so much anxiety in the midst of COVID. The individual navigation work includes referrals to needed social services. Our partnering group, Knew This, has mapped resources both for HIV prevention and care as well as COVID-19 resources for the transgender community. That's going to be integrated into our navigation program. The study design is a randomized waitlist control trial in which we allocate 200 participants to an immediate intervention. And then that's about 3 months of group sessions and 6 months of individual navigation. And the other participants are in a waitlist control arm and they'll be offered the same intervention 1 year later. So the main trial phase is 1 year of person time for the intervention and waitlist control participants. And the second phase of the study, which is the delayed intervention phase, is when the control arm participants will receive MANAs. And it simultaneously gives us an opportunity to follow the intervention arm participants for 6 more months so that we can look at persistence of intervention effects. So our follow-up data collection occurs every 3 months. That includes brief monitoring surveys at the 3-month and 9-month visits. And that's just really to document outcomes, prevention, uptake. And we have comprehensive visits and surveys that are conducted every 6 months, starting at enrollment. And in those surveys, we'll be collecting all the data on stigma and discrimination and other social measures that we'll be following for our mechanisms aim. We also have a qualitative component. Interviews will be conducted with 18 participants at 2 time points to provide context into our exploration of intersectional stigma and gender affirmation, including how these impact engagement with the intervention and with prevention uptake. Okay, so rolling recruitment is ongoing now. We'll be enrolling 400 participants. That's going to take place over approximately 1 year, COVID permitting. And we'll be recruiting participants from multiple different sources, including some standing cohorts that Amelia and her team have been following. Also those accessing services from our partner facilities and people who we've reached through community outreach and referrals. Data collection is conducted in 3 sites at I actually have in my next presentation a picture of where all these things are. So data collection is conducted at our Knew This office and also 2 highly accessible clinic locations, one being a municipal health facility and the other being a state health facility. And I think I already talked about the survey follow-up. The only thing I didn't mention is that we'll be collecting dried blood spats to monitor adherence to PrEP for those who accept initiation.
So we've chosen to measure intersectional stigma with the Intersectional Discrimination Index by Scheim and Bauer, which includes subscales for anticipated stigma, as well as enacted day-to-day and major discrimination. And what's great about this measure is that the items are all attribution free. So we don't ask people to attribute the stigma or discrimination that they experience to any single part of their identity, taking a more intersectional approach. So the items are prefaced as questions about experiences related to who you are. And then we're using an adapted version of the resilience to stigma measure. For consistency, we're also prefacing this measure with because of who you are, rather than referencing anyone's social identity. These questions will be asked every 6 months during the social measures longer survey over the course of the study. So we started enrolling on November 26, 2020. We've trained and hired 16 peer navigators so far. 94 participants have been enrolled. We've got 3 groups that are ongoing. The rate of missed appointments is relatively low, especially considering the context of COVID. We're seeing very low knowledge of OraQuick, or the oral HIV self-testing, although we also see very high acceptance rates. So people are really taking home the HIV self-testing kits, although they do express concerns about self-testing without support from a health provider. In the groups, as always, trans pride and trans identities are very big discussion topics, and folks are really interested in hashing that out with each other in the group setting. As I mentioned briefly earlier, we do see some challenges related to the distribution of PrEP, just due to the low number of providers who are currently prescribing PrEP. There's some politics involved in terms of who is delivering PrEP, especially in the context of research that is embedded in clinics. So we're working with that. A lot of our focus right now is on adapting to COVID-19 and assuring that our peer navigation team is getting all the needed training on the original MONUS content, as well as COVID-related support and resources. They are able to do these groups in person right now, which is amazing. The enrollment rates are incredible given the context of COVID right now. The on-the-ground team is really doing incredible work. So we're also dealing with the Brazilian government's dismantling and underfunding of the public health sector, which is happening rapidly. There's some safety issues in certain sections of Sao Paulo that the peer navigators have had to work around. And just in terms of continuity of peer navigators, you know, the health disparities that impact trans women in Brazil also impact our peer navigators. And with that, I'll say thank you and dedicate this presentation to Bruna, who is second from the left in this picture. She's a really amazing, inspiring activist. She was a star peer navigator, an inspiration to the trans women's community in Brazil. And she was a huge part of our Trans Amigas intervention. And she passed away last year. So with that, I think should we go ahead with the next presentation or take questions now?
I was going to recommend maybe going on to the next presentation so that we make sure to get all the content out there. But that was a little bit longer. I don't know if, so just maybe be mindful so there is time for questions. But
great, thank you.
Can you guys see that?
Mm-hmm. Yes.
Okay, why can't I see it though? Okay, so I'll just jump into the next presentation then. So this award, so you'll be seeing some repeat stuff going on here because this K24 has components happening in both Brazil and South Africa. So this award is really a culmination of things that I've been working towards. I've had active research portfolios in Brazil since 2001 and in South Africa since 2009. So this K takes my research in both countries in sort of a new direction and includes a large mentoring component that sort of sets apart this K mechanism. So the title of my K Award is Training and Implementation Science Research to Improve PrEP Services for People at Risk of HIV. So a little bit about the K24. This is a mentoring award, and it represents an investment both in the mentor's research and in the mentor's mentoring capacity. So there are really three components in the K24. The first is support for the candidate's patient-oriented research, and it provides time and support to continue to develop a research portfolio. So it's directed towards mid-career or associate, usually associate faculty, so that you already have a rich line of research, and this award really provides support to develop in new directions and build on what you've done so far. The second aspect of the K24 is support for the mentor to become a better mentor and to really develop their mentoring capacity. So this gives associate faculty who've already been putting a lot of time into mentoring a chance to stop, reflect, and learn new mentoring tools and skills. And that's something that we almost never get to focus on. So it's a real privilege to get to do that. And finally, the third component is time to support direct mentoring of early career investigators. So approximately 25% of the time in my K is dedicated to direct mentoring. I'm going to be mostly talking about the research portion of my K24, and I think Jay is going to focus on the mentoring aspect of the K24. So part of, like I said, is training for the candidates. So I'll be getting training in mentoring skills. I'm going to be working on gaining additional mentoring competencies, things like effective communication skills, fostering independence, and promoting advancement of my mentees through sponsorship. Those are just some of the topics I'll be focused on. I have two mentoring coaches, Mallory, who's did us the favor of presenting us today, and Margaret Hanley, who's in the epidemiology department. And I'll also be doing some coursework towards mentoring skills. I'll also have time to study, really train in subject matter, which is implementation science. So I'm seeking to extend my implementation science expertise and learn some new approaches. And there's a whole different variety of things that I'll be doing towards that end. So as I was noting, this really extends my research. So most of my current NIH-sponsored research is in behavioral and social intervention work. But this K24 focuses on addressing clinic and health system level barriers to the provision of evidence-based care. So it's sort of an extension of what I've been doing and takes another side. I'll be focusing on using implementation science strategies to improve delivery of pre-exposure prophylaxis, so PrEP for populations with poor access to tailored HIV prevention programming. And it's going to extend my opportunities for mentoring, especially within the field of implementation science. So just a quick bit of background. Most folks on this call probably know as much about PrEP as I do. So it's very efficacious when it's taken as prescribed. It's available on paper in most countries for groups who can benefit the most from PrEP. But international rollout has been incredibly uneven. There's major accessibility barriers. One of the WHO reports said that half the countries offering PrEP only do so in specialized HIV treatment clinics. And you can imagine the kind of stigma issues that you run across when there's very few areas, very few places where you can actually access PrEP, and they're already stigmatized. There's also major information barriers. So there's a lot of groups that don't know about PrEP or don't know accurately about PrEP and how it works, providers that lack information, or providers that don't feel comfortable prescribing it. In Brazil, PrEP has been available since 2017 through the universal healthcare system. But, as Jay noted in the earlier presentation, by 2019, only 335 transgender women were known to be on PrEP. Transgender women have, twice the incidence of HIV incidence that you see in MSM, but, they take PrEP 20 times less frequently. So there's major access barriers. But we know that people are interested in PrEP. It's really an issue of being able to attain it in the health system. In terms of PrEP in South Africa, PrEP has been in the national guidance since 2016 with targeted rollout for adolescent girls and young women at select sites starting in 2018. But by mid-2019, about half of the adolescent girls and young women who are offered PrEP accepted initiation in pilot sites, but only half of them were actually even offered PrEP at all. So this speaks to some of the barriers that really lie on the provider side of PrEP delivery. I also just wanted to note that in many populations, initiation is only one hurdle. It's the persistence of use, and that's going to require a lot of social and structural supports that aren't in place yet. So taking into consideration what's going on in these two countries, I I feel that the biggest gap right now in terms of research and programming for the populations that I've been working with in South Africa and Brazil, well, one of the biggest gaps is really quality of implementation and dealing with the delivery supply side. So we are currently doing, as Jay noted, as our earlier presentation noted, research around creating demand and supports to the groups who need it. But this K24 really hones in on context-specific delivery approaches that address clinical and health system barriers. So AIM-1 is about the implementation context. We'll be characterizing the PrEP delivery context through conduct of mixed methods assessments, organized around the CFR domains. That's the consolidated framework for implementation research that I can talk more about later. We have AIM-2, which is implementation strategies. So we'll be working with stakeholder working groups to address, to determine sort of what mix of implementation strategies can address the implementation context barriers that were discovered in AIM-1. And then we'll choose and tailor those approaches to the context. And AIM-3 is an implementation pilot. So we'll choose strategies in AIM-2, and then we'll pilot those chosen strategies at one clinic in each location to assess feasibility and acceptability. So in Brazil, I'll be working with the same group that we're working with doing Manas por Manas with the Santa Casa School of Medical Sciences in Sao Paulo. I wanted to note that this is a map of the subway system in Brazil, in Sao Paulo, which is sort of easier to follow than like this amorphous city map filled with details. But we'll be working with clinics that are in Campos Elíseos is in the north, sort of central north area. CRT is in sort of the southern area near our Nudes office. And the CTA Guaianazes, which is a testing center nested into a primary care clinic, really hits a large population of transgender women that are seeking care on one of the far sides of Sao Paulo. So all of these sites serve large transgender populations. All right, next slide. In South Africa, I'll be working with the MRC WITS Rural Public Health and Health Transitions Research Unit. It's a mouthful. It's a demographic surveillance site in the northeastern area, sort of border near Mozambique in South Africa. I'll be working with site PIs there that I've had research ongoing with since 2009. And we'll be working in 4 sites. There's 9 clinics within the demographic surveillance site, the Agincourt surveillance site, but we're going to choose 2 community health centers and 2 primary clinics, and we'll select those based on high and low ratings of clinic quality from research we conducted in 2019. So the AIM-1, again, is understanding context, and we're going to do that by conducting in-depth interviews with 20 to 25 key informants in each site. We'll be talking to clinic managers, providers, local policymakers, and community advocates and representatives. And that's going to be sort of based around the 5 CFR domains. So those domains include the characteristics of the intervention, in this case, PrEP and its delivery, the outer settings, so what are the external policies that are in place that act as barriers or facilitators to delivering PrEP, the inner setting, which is sort of more about the clinic, its organizational culture, leadership culture, and the implementation climate, and then the implementation process itself, so how stakeholders are engaged and projects are rolled out, and also characteristics of the individuals, so the population that you're working with. We'll be gathering quantitative data. That's going to include things like estimates of the target population and information on current PrEP delivery, uptake and retention. Both sites have electronic registries that we can use to track PrEP distribution, which makes life easy. And we'll be convening stakeholder working groups, both prior to and following data collection, and then again a few times throughout the project to make sure that we're really reaching all of the different issues that need to come up and that we have their help with interpretation and choosing strategies, as I'll talk about in the next slide. So AIM-2 is an implementation strategy aim. We'll be identifying strategies that are responsive to our AIM-1 findings. So we'll convene stakeholder working groups and then select from a large menu of strategies, whichever ones seem to best address the issues that we came up with in AIM-1. So for example, if AIM-1 data reveals that provider attitudes about adolescent girls and young women's sexual practices are negative among the providers, then we can choose a strategy that's provider training, understanding the needs of adolescent girls and young women. So we'll use logic models and matrices to help define the strategy's objectives, targets, actions, and we'll be exploring various different options, not just how to make something better, how to get the clinic to better deliver these PrEP, but also different community-based strategies and integration with other services. Oh, I just wanted to throw up this great logic model that is an example of a template from, I think it's Smith, Rafferty, and Lee, that the ISKI, the Implementation Science Collaboration Initiative, has put together. And it really lays out the use of our AIM-1 data, like the left-hand column, to shape the implementation strategy, which is the second column. And then we can note the mechanisms of action and the expected implementation service and clinical outcomes. So we'll be working with spreadsheets sort of like this, with logic models, with our stakeholder working groups to select our strategies to improve PrEP delivery, and then to monitor them in AIM-3. So the implementation pilot aims to test the strategies that we selected in AIM-2, and then we'll assess feasibility and acceptability and tailor the protocols for those. And we want to know if strategies were adopted, acceptable, implemented as planned. We'll do that through implementation monitoring visits, provider and clinic manager interviews, and through tracking PrEP delivery over the course of the 6 months of this project of the pilot. We'll be monitoring implementation outcomes and program outcomes, and we'll be convening stakeholder working groups ahead of time, and then at the end of the monitoring period to discuss our outcomes and further adaptation of strategies. So I just wanted to end really saying that there are opportunities for mentees, US, Brazilian, and South African, in each stage of the research, and these include participating in planned activities within the research scope, but also a possibility of proposing ancillary research. So I just jotted up a couple of ideas, like for example, within AIM-1, someone could help with qualitative data coding, analysis, and writing if they want to gain more experience there. But they could also propose something like adapting new measures of the CFR factors, because almost all of them that have been proposed to date are based on US models, not Brazilian or South African. So that would be like a great research project. You know, in AIM-2, someone could propose to use discrete choice experiments to tailor implementation strategies with provider surveys. So there's a lot of different things that can be proposed as part of this research. And with that, I just want to acknowledge my funders, my colleagues, my mentors, and also my mentees. And I'm going to end with this quote from someone who reminds me to never stop learning and never give up on being a better version of myself, Nelson Mandela. Thanks. Now I have to figure out how to stop sharing.
Never stop sharing. Thank you, Sheri.
Never stop sharing.
Never stop sharing. We can stop sharing your slides too, right? But that's about all. And great. Thank you so much for the invitation and the opportunities for mentees. That's fantastic. And I hope people bang down your door with interest, because there's lots of exciting opportunities. So I'm going to move on to Jay's presentation. And I think some of the overview of the mechanism, I think, has already been laid out. So that should allow Jay to jump right into some of the specifics of her project. All right, Jay, thank you.
Can you see this?
Yes.
Yeah.
Okay, great. So as Sheri mentioned, I am going to focus a little bit more on the mentoring aspect of the K24. My K24 is entitled An Intersectional Approach to Mentorship and Patient-Oriented Research on Substance Use and HIV. Sheri went over what the K24 funding mechanism is, but just to reiterate, it's really to devote more time to the mid-career investigator to augment existing capabilities and existing program of research in patient-oriented research, and also to provide protected time to do mentoring with junior clinical investigators. So this is from the FOA. Typically, K24s are awarded at the associate professor level. And the associate professor usually has a pretty extensive existing program of research, as well as experience providing mentorship. And as Sheri also mentioned, the K24 provides about 25 to 50% FTE support for the investigator, as well as $50,000 in research costs. So it's not a huge research grant, but enough to sort of augment the existing program. Also, Sheri mentioned there are three main sections of the K24 proposal. You talk about the candidate's background in research and their goals for career development. You create a research plan that is usually building on the existing program of research. And then you also present a plan to provide mentoring. So I'm going to use these three sections to shape my presentation today. The overall aim of my K24 is to develop and implement intersectional approaches to mentoring and patient-oriented research, primarily focused on HIV prevention and treatment interventions with transgender and gender diverse people who use substances. So my K24 came from NIDA, and I'm doing a little bit more of an emphasis on substance use than I've done in my past research. This is just a little bit about my background, so you can kind of see where I am at the stage of receiving a K24. My program of research has been very community-based, focused almost entirely on transgender and gender diverse communities, looking at stigma and discrimination and how those factors relate to health behaviors and outcomes. And I've also been very much focused on developing, implementing, and evaluating health promotion interventions focused on HIV transmission and acquisition, behavioral change, community programming, and increasing access to culturally appropriate healthcare for trans and gender diverse people. My program of mentoring has focused primarily on mentoring underrepresented minority folks in medicine and folks who also or identify as sexual and or gender minorities. I've also done a lot of supporting URM faculty through my service and leadership in several diversity initiatives across UCSF and the UC system wide. And my training and mentorship and leadership to date primarily came from seminars from the American Academy of Medical Colleges, as well as the CFAR Mentoring the Mentors program. So the training that I proposed to gain to expand my scope of currently funded patient-oriented research was focused in the areas of substance use, implementation science, and intersectional stigma. I am retaining my focus on trans and gender diverse communities. That's really where my heart and passion lies. And looking at identifying best practices for the implementation of the interventions that I and my teams have been developing and testing over the last decade or so within the context of HIV prevention and treatment, and expanding that to include substance use. My mentors are Dr. Elise Riley and Tor Nealons for looking at substance use, Dr. Alvin Gang around implementation science, and Dr. Lisa Boleg to really grow my perspective and my expertise in intersectional stigma specifically. So in terms of my plan for mentoring, I propose to develop a mentoring approach informed by an intersectionality framework to address the unique needs of URM and SGM mentees and to produce new scholarship in this area. I aim to work with existing mentoring programs to develop content and expertise that addresses diversity in academia and really aims to meet the needs of mentees who are underrepresented in medicine using an intersectional lens. I'm also developing opportunities for distance mentoring of researchers interested in transgender health. And this is to address the rapidly increasing interest and the corresponding demand for mentorship in this research area. So this transgender health has just really blown up in the last 10 years or so. So there are fewer senior level or mid-career level researchers to offer mentoring to the many trainees who are interested in transgender health. So distance mentoring is one way for me to address some of that need. I'll also gain additional training and mentoring. I'm sure Mallory regrets ever introducing the term grand mentor because he will be known as our grand mentor forever and ever. I'm also going to complete the CTSI mentor training program. That's actually being offered in spring 2021. If anyone's interested, the application deadline is March 1st. Come join me in that cohort. And I also just recently completed the Faculty Success Program from the National Center for Faculty Development and Diversity and can highly recommend that program as well. I'm not going to go really into a lot of detail about my research strategies, but just to give you a flavor of the types of aims that I proposed, which is an interesting contrast to how Sheri set hers up, because her aims are very much build on one another, whereas my aims are really pretty separate aims that are building on different projects in my current portfolio. So the first aim is to characterize the relationships between experiences of transgender-related discrimination, substance use, and engagement in HIV care among transgender women living with HIV. So I'm going to be using baseline data from a cohort of transgender women living with HIV. We enrolled 277. That they were enrolled in an RCT to test the efficacy of Healthy Divas. Hi, Brianna McCree. She's the queen of Healthy Divas. We will characterize experiences of transgender-related discrimination, types and frequencies of substance use, including polysubstance use, and then explore how these relate to patterns of engagement in HIV care, including medication adherence. And then specific aim 2, which kind of addresses that implementation science training aim that I proposed, was to expand an existing implementation study that we are currently doing with an organization in Oakland called CalPEP. Many of you are probably familiar with them, where we're going to be nesting a qualitative study into that implementation evaluation project to really hone in on evaluating what the impact of substance use is on the implementation of Healthy Divas. Substance use was definitely considered when we were developing Healthy Divas. It comes up a lot in Healthy Divas, but we don't really have a strong understanding of how much of a barrier it is, what we can do to kind of address substance use in the context of implementation of Healthy Divas. And so we're going to be using the RE-AIM model and group model building to generate insights at the intersection of HIV care engagement in Healthy Divas, and substance use. And then finally, the third research aim is also nested within the study that Sheri and I are MPIs on in Sao Paulo, Brazil. And this is to, we're going to be conducting a qualitative study, again, to kind of deepen and expand the scope of our current randomized control trial of Manas por Manas, really to dig into informing measurement refinement and future intervention strategies around the reduction of intersectional stigma. So we're going to be triangulating perspectives on multi-level intersectional stigma and really getting into more of the structural level structural stigma by interviewing policymakers, organizational leaders, healthcare providers, folks who were not included in the qualitative portion of the original Manas por Manas design. So again, my plan to provide mentoring is really about advancing emerging scholarship on both intersectionality theory and academic mentorship. So I propose to apply intersectionality theory to mentoring to create a new theoretically grounded model of mentorship across differences. And as we know, particularly within HIV research, there's a strong call for researchers who reflect the populations that we're serving. And intersectionality really has a extreme potential to offer a unique lens through which to view the mentor-mentee relationship and really meaningfully inform an approach to mentorship across differences. This definitely requires a lot of cultural humility on the part of the mentor. It's really important. Based on the literature, we know that it's really important that we explicitly acknowledge and address how race and other diverse identities shape our experiences of our institutional environment, as well as the mentoring relationship. And when we can really acknowledge and address those explicitly and think about those in a meaningful way, it improves the mentorship relationship and ultimately benefits the mentee. So I'm expanding my current mentoring program and creating new directions in mentorship. As I mentioned, intersectional mentoring, the distance mentoring, as well as writing intensives. So I work with my mentees a lot around developing writing rituals, writing productivity strategies, strategic planning around writing projects to help mentees really think about how to be productive in their writing and how to make writing an enjoyable and integrated part of their academic career. Really want to shout out to my current mentees who are here. Thank you so much for being here and for your support. And I also just learned so much from my mentees. All of the research aims that I mentioned include opportunities for mentees to be involved. So I really want to stress that, as well as I set aside $5,000 per year of the research costs specifically to support unfunded aspects of mentee research. So that was another real privilege and opportunity within the K that we may not always have within other types of funding mechanisms. So extra support for mentees and opportunities for mentees are really built into the K24 mechanism in a thoughtful way. So thank you. Try to leave a couple minutes for questions.
All right, thank you so much, Jay. Okay, let's just open it up for questions for either of our speaker on any of the projects that they have oriented us to. You can either just unmute yourself. I can also look at the chat if anyone's got anything.
People may be filling out the poll that just popped up.
Yeah, multitasking. All right, I see names of people that I know have questions. All right, I'll jump in then. For the opportunities for mentees, how do you recommend people reach out to you? What sort of process works for you in terms of you know, how you decide, how they decide, how you decide whether they might be a good match for working with you in some of these opportunities? What do you recommend? How do you like to work with people? That's to either of you.
You want to go for it, Jay?
Sure. Yeah. I mean, I very much encourage folks to reach out to me directly, and I really like to get to know a person, get to know what their career goals are, get to know what their training goals are, talk to them about what my program of research looks like, where the opportunities are, and so that we can kind of mutually get to know each other and figure out if there's a match between that person's existing expertise, their training goals, and what I can provide and what the infrastructure of my program of research can provide. And I'm really happy to talk to anybody about that, even if there's not an immediate clear idea or match that that the person is coming to me with. I really enjoy the process of exploring that in collaboration.
Yeah, I don't really have much to add to that. I agree. Reach out. We can talk if you're interested. And I think that there's, so many different ways to create a relationship based on either on research that's ongoing or on new ideas. So when I meet someone and it doesn't seem like there's a great match in terms of what I have going on and what they need, I usually try to find someone else within CAPS or within UCSF or even elsewhere that might fit the needs of the mentee. So it's always worth reaching out, I would agree.
Great. We have a couple more minutes. We can tackle another question.
Come on, we're not scary at all.
Janet Myers, you look like you have a question. Your video's on. You look pensive. You have a question, right?
No, I'm fighting with petty cash right now. But it was a great presentation. I loved it. You guys are seamless. I don't think I have anything substantive to add. I think you're both brilliant. That's all.
Oh, thanks, Janet.
It's true.
I have a question.
Margarita.
Jay, I'm really interested in hearing about your ideas for an intersectional approach to mentoring. What is your approach to figuring out that approach? And like what resources and people or mentors are you relying on to help you think about that?
Yes, thank you for that question. I am very much relying on Dr. Lisa Boleg, who is a consultant on this project. So I'm grateful that I get to pay her for her time in mentoring me. She was doing it for free before, and now I get to give something back. And really thinking about the mentorship relationship as a collaboration, really thinking about the fact that due to structural inequalities in access to education, due to the sort of white dominant norms and institutional environments that have resulted in massive inequalities in who is currently available for mentoring, I really think it's important to think about the elements that the mentor brings in terms of their intersectional identities, have the mentor really reflect on those and how those influence the mentoring relationships. We often think about mentees in terms of, sort of multiple identities and how intersectional experiences impact the mentee. But from the mentor side, how do my own identities and my own experiences impact what I bring to the mentoring relationship, and how am I able to reflect on that as a mentor and subsequently, support my mentees in a more meaningful way, and also understand that the identities that they bring to the institutional environment, to the academic, their academic career, how those might impact their experiences, and really acknowledging that within the context of the mentoring relationship in a really explicit way.
Great. Thank you for that, and thank you for the question. We are past time, but I think our speakers have made it clear that they are open and receptive to hearing from you, and I'm pretty sure it's not just mentees, but anyone who has questions or wants to discuss the exciting work that's just getting started. So thank you to both of our speakers. You covered a lot of terrain, and it's much appreciated, and I'm thrilled to hear more details about what's happening. So thank you.